Good morning and welcome to Child Psychiatry Grand Rounds. It's my really great pleasure to introduce Dr. Sandra Loo, today's speaker. Dr. Loo will be speaking on brain stimulation for ADHD, emerging treatment options. Dr. Loo is a professor of psychiatry and the director of the pediatric neuropsychology within the Department of Psychiatry at the UCLA David Geffen School of Medicine. She's a licensed clinical psychologist and translational researcher whose work over the past 25 years has encompassed genetic, electrophysiology, and neurocognitive biomarkers within ADHD and other neurodevelopmental disorders. A recent research interest has been the development of treatments using non-invasive neuromodulation for ADHD. So she's published over 150 peer-reviewed journal articles and book chapters on these and related subjects. And her teaching and clinical activities are focused on comprehensive neuropsychological assessment of youth with pediatric and psychiatric disorders such as traumatic brain injury, epilepsy, brain tumors, ADHD, specific learning disabilities, mood and anxiety disorders, pretty much the whole spectrum. And she oversees research and clinical training for a full spectrum of trainees interested in specializing in ADHD and related neurodevelopmental disorders. So without further ado, Dr. Loo.
Good morning. Thank you, John, for that lovely introduction. Let's see. Good morning, everyone. I'm super excited to talk about brain stimulation treatments for neurodevelopmental disorders, in particular ADHD. Before I start, I want to give you my disclosures. This work has been supported primarily by the National Institutes of Health, for Dr. Jim McGough and I. We've done this work together. And neither of us have any financial conflict of interest with the product, the TNS device that I'll talk to you about today, or the company that produces it, or no other conflicts of interest. I also I've been instructed to tell you that any questions you might have can be submitted through the Q&A function, and we will address those at the end of the talk. So today I was just going to do an overview of non-invasive neuromodulation treatments, talk a little bit about the efficacy of two fairly well-known non-invasive neuromodulation treatments, rTMS and TDCS for ADHD, and then go over trigeminal nerve stimulation, which is what we've been studying for ADHD treatment. Talk a little bit about the safety, efficacy, and neural mechanisms underlying treatment, and then show you a little bit of the work we've done on predicting TNS response. So the challenge, as we see it, is that ADHD heterogeneity, which likely arises due to multiple causal pathways, contributes to variability in clinical presentation, underlying neural mechanisms, as well as response to treatment interventions. So as we all know, psychostimulants are the gold standard of treatment for ADHD. However, there are problems with psychostimulants. The first and most pressing being suboptimal response. So, a significant minority of children, 30 to 40%, may not have an optimal response to psychostimulants, and or adverse side effects such as sleep difficulties, emotional lability, growth delays, etc. In addition, we see other problems with psychostimulant medication treatment, such as treatment noncompliance, a lack of long-term functional improvements, substantial ambivalence on the part of parents and adolescents with ADHD, as well as racial disparities in utilization. So basically, I think we have been trying to address this critical need for empirically supported treatments that are non-pharmacological for ADHD, as well as a reliable method for predicting which treatment will be effective for which particular child. So we started looking at non-invasive neuromodulation, and really what this is a way to target neural circuit activity using devices that are either worn on the outside of the body, on the scalp, or the forehead. There are two theories about how non-invasive neuromodulation might work, and they are not mutually exclusive. It could be one or both. There's first the electroceutical theory, try and say that 3 times, where Basically, neurotransmitters are enhanced by the electrical stimulation, which alters the activity or communication between nerve fibers to achieve therapeutic effects. Another possibility is an augmentation theory, where the therapeutic benefits arise primarily through physiochemical means, such as changing transmembrane potentials, membrane permeability, or electrocortical activity of receptors under the influence of the applied electric field. Like I said, it could be one or both working together. And why do we think neuromodulation might be useful for pediatric populations? Well, we know that neuromodulation techniques can precisely target neural circuits and bring about change in a very precise manner. The developing brain, as we know, is highly plastic in childhood and adolescence, so potentially making a change in childhood and adolescence could change the trajectory of brain development. Children and adolescents show accelerated neuroplasticity, so it might not take quite as long to bring about change in the brain. And then it may be effective in pediatric populations particularly at early stages. So we have this ability to potentially intervene at very early stages of disorder and achieve quite a good therapeutic effect. All right, so repetitive transmagnetic stimulation, RTMS, is essentially applied through a coil that is above the head, and brief intensive pulses of electric current are delivered through the coil to the brain and generates an electric field, which is generally an action potential. Okay, so it's current flowing through the brain parallel to the surface of the coil. There are two different kinds of RTMS. One where it's more conventional RTMS at high and low frequencies, as well as theta burst stimulation, which is a lower stimulus intensity and tends to take less time than RTMS. In general, high frequency RTMS promotes cortical excitability, whereas low frequency RTMS inhibits cortical excitability. And work done by our own Jennifer Levitt here suggests that RTMS leads to increased GABA in the dorsolateral prefrontal cortex, which is related to clinical improvement in depression. So RTMS is FDA approved for treatment-resistant depression, and I believe OCD as well. So that's maybe where you've heard more about RTMS. In terms of ADHD, there have been a number of studies where there have been sham-controlled studies where they've had 10 to 20 daily sessions, primarily in adults with ADHD, and the findings have been quite mixed. I've just listed two notable recent studies. One was an RCT that used 15 sessions of 18 hertz stimulation. They actually had three groups: active versus sham versus active control. And they stimulated the dorsolateral prefrontal cortex and the inferior frontal cortex. And this did result in significant improvements in ADHD symptoms in adults with ADHD, as well as improved performance on cognitive tasks as Stroop, and I believe positive changes in the EEG. However, this was a semi-blinded study. The investigators who were administering the RTMS were not blind to active versus sham. And so there's that slight methodological hiccup. And then there was a large pediatric study where they used 30 daily sessions of 10 hertz stimulation over the right dorsolateral prefrontal cortex. And this was combined with atomoxetine. And compared to atomoxetine alone or RTMS alone, and this the combination of the two treatments improved ADHD symptoms significantly. However, there was no sham condition included, so a replication would be needed here. So the majority of studies overall have reported no side effects or serious adverse events or seizures, for example, other than the kind of commonly transient itching over the site of the stimulation or a headache. So even though, so I've kind of given you some good examples of successful stories. So far, the studies have been fairly mixed and mostly with adults with ADHD. There's been a question about whether RTMS should be used with children, and I don't believe it's being used in children younger than perhaps 14. Even though I think people are definitely thinking about trying. Given some of the methodological weaknesses, I think the evidence base so far is weak, and I think much more research is needed before considering RTMS as a treatment for ADHD. Transcranial direct current stimulation, or TDCS, is it's not really jumper cables, but it is actually basically two electrodes with an electric current that is passed between the electrodes, and it's a weak but persistent electrical current, okay, between the anode, which is positive, and cathode, which is negative. It's become quite popular with gamers, as to increase focus. They have home kits where people can build their own TDCS headset and then subsequently wear it, which is a little frightening. But it does increase or decrease stimulation, neuronal excitability through spontaneous discharge rates, which is affecting cortical function. TDCS is easier to apply, it has lower financial costs, and tends to be less painful than TMS. And the side effects typically involve tingling, transient itching, and reddening of the scalp site of stimulation in some people. In terms of ADHD, there have been quite a few studies, and there was a recent meta-analysis that reported a significant overall effect on inattention and impulsivity, but not hyperactivity. Again, I'm going to go ahead and point out a couple of notable recent studies. This RCT was 15 sessions of TDCS over the right IFC, and it was paired with cognitive training. So it was cognitive training with and without TDCS in adolescent males with ADHD who had, and this was actually Katja Rubia's group in the UK, where there was basically no clinical or cognitive effect of active TDCS over sham TDCS. However, Katja Rubia was also part of this study. It was actually a multi-site study, very large, where they had an RCT where they did 28 sessions of TDCS over right dorsolateral prefrontal cortex, which did result in reduced inattention symptoms in adults with ADHD. So if there is an effect, it does seem to be strongest on inattention, which is great. It may be more effective with adults. And one of the things that I'm seeing is perhaps more sessions. So earlier TDCS studies had very few sessions of TDCS and produced no effect. You can see as you increase the number of sessions and therefore the treatment length, it seems that the effect on perhaps inattention is more pronounced. So the methodological issues preclude consistent conclusions. I think the latest results are very promising, and figuring out, I think both for TDCS and TMS, I think one of the main research goals moving forward would be figuring out where to stimulate and how much stimulation is needed to achieve a therapeutic effect. So in summary, repetitive TMS has greater specificity in targeting neural regions than TDCS, but it is more expensive and it tends to be more painful. Stimulation parameters and study designs are really heterogeneous. There hasn't been a very consistent method for doing some of these studies. There needs to be more standardization and larger sample sizes. The long-term and developmental effects are unknown because the studies are fairly new. So that's something that I think still needs to be explored. And I will just point out that neither TDCS or RTMS are FDA approved or cleared for any pediatric disorder, including adolescent depression. Okay, so let's talk a little bit about external trigeminal nerve stimulation. This is essentially what the stimulator looks like, and this is how it's applied. So the idea is that while children sleep, they wear this electrode on their head, and the stimulation, this is about the size of an iPhone, a small iPhone, and this basically the electrodes are plugged into the stimulator, which is either worn on the pajamas or placed on the pillow next to the head. The stimulation is mild and can be adjusted according to comfort level, and this is commercially available by prescription. In terms of neural mechanisms, it seems as though this TNS unit delivers electrical stimulation to the cranial nerves, specifically the V1 branch of the trigeminal nerve, and this provides external stimulation of the brain via the cranial nerves. So the trigeminal nerves, there's V1 here, V2 here, and V3 down here. Stimulate the nucleus tractus solitarius, which comes in here through the brainstem. And from there, stimulation radiates out into subcortical as well as cortical structures. There have been several studies that have looked at trigeminal nerve stimulation, primarily in migraine, adult migraine. And the most consistent fMRI effect has been in the anterior cingulate cortex, which I'll just mention has been an area that has been implicated in the pathophysiology of ADHD. All right, so Jim McGough and I have conducted 2 previous studies. One was just an open label, small feasibility study of TNS, where we did observe a very large effect of the TNS stimulation on ADHD symptoms. We used this data as preliminary data for an RCT that NIH funded, and we carried that study out. You're going to hear more about the data in a minute, and that data, that study was published in 2019. And, you know, I think the same month that the study was published, the FDA, based on our data, issued clearance for this device as the first non-pharmacological device-based treatment for children with ADHD 7 to 12 years old. So the sample included 62 children aged 8 to 12 of normal IQ. We used a semi-structured diagnostic interview for ADHD. And the TNS trial lasted 4 weeks of nightly active or sham TNS treatment. We had an assessment battery that included behavioral, cognitive, and EEG measures at baseline and after treatment. There were no differences between the active and sham group in terms of any of the demographics or clinical severity of ADHD or resting state EEG power. The treatment blind, we tested through something called the Early Impressions Questionnaire, showing that the fidelity was maintained at the treatment blind. And there was excellent compliance. Children actually parents and children liked using the device. It was well tolerated. There were minimal side effects. So over the course of the trial, let me just orient you to this graph. So this is time along the x-axis, so from baseline to the end of treatment. And this is the ADHD-RS total score. This orange line is the active treatment group, and this blue dotted line is the sham group. So you can see that at the first week of treatment, both groups showed some response and some improvement, after which the sham group plateaued and the active treatment group continued to improve. So this treatment group by time interaction was significant, suggesting that active TNS does bring about a larger change in ADHD-RS total scores. Using a measure of the Clinical Global Impression of Improvement score scale of 1 or 2, so very much improved or much improved by a blinded clinician, you can see by week the number of responders in the active TNS and sham TNS groups. So you can see there was a change that increased somewhat linearly, maybe by week in the active group, and stayed fairly flat in the sham group, and this was a significant difference. Based on this data, there is an estimated treatment effect size at week 4 of 0.5, which suggests a medium size effect. And just to compare, we can look at non-stimulant medications such as atomoxetine or guanfacine, and that's quite similar in terms of effect size, but smaller, of course, than stimulant medications that have a large effect size. Comparing the TNS effect to all other non-pharmacological treatments, TNS had a larger effect size than the pooled effect sizes of all other non-medication treatments. In terms of side effects, here is just a count of side effects for the active and the sham group. Overall, side effects were very mild, a couple moderate in clinical significance. All subjects completed the trial except for one subject who was randomized to sham. So we did not have any children drop out of the trial, and there were no serious adverse events. So turning to the neural mechanisms underlying treatment response, which is something that I love to do, we looked at eyes open resting state power at the F4 electrode, which is located here on the right frontal area. So down here on this graph, we have frequency bands across the bottom, and then relative power in decibels on the y-axis. You can see here, first, this solid orange line, red line, is the active group at baseline, and the dotted line represents the post-treatment spectral power. So you can see that there was a broadband increase in spectral power for the active TNS group, whereas in the blue, this sham group, here's the solid line, which is the baseline, and then the dotted line is the sham group, essentially no change in spectral power at the end of treatment. So this was a significant interaction effect. This is a topograph of the week 4 EEG beta power. So you can see here in active TNS compared to sham TNS, you see a significant increase in activity in the mid to right frontal region. Also in the more posterior regions, parietal to occipital region. And however, at the p-value level, I think there was just more variability in the posterior regions, and also the sham group had some posterior activation. So the p-values here at the mid and right frontal were significant. These were trending, but not quite there. And then just as a close-up, for example, with gamma power, you can see the interaction here from baseline to week 4 is an increase in power in the active group, whereas in the blue line, the sham group was essentially unchanged, probably pretty much within confidence intervals across the trial. And then you can see, so this, some of the spectral power at the right frontal and mid frontal, both theta, beta, and gamma correlated with ADHD-RS hyperactive impulsive symptoms and total significantly. So this suggests that as theta goes up, increases, the ADHD-RS hyperactive impulsive and total scores go down, and same direction for all of these correlations. So we also wanted to model connectivity. And so we, my lab has been doing a lot of work in looking at cortical source EEG and then modeling connectivity between brain regions. So what it looks like is that these right frontal connections are decreased in the active versus sham group. Okay, so here's just a graphical representation of connectivity which is renormalized partial directed coherence. In terms of the baseline to week 4, the sham group has an increase, whereas the active group has a decrease. In particular, these connections from the midcingulum to the right midfrontal regions were associated with treatment change in the ADHD-RS total. So as connectivity goes up, so do scores on the ADHD-RS. Same with the midcingulate to the midfrontal connections. So in particular, these connections with, for example, the left superior frontal did not have significant correlations with ADHD-RS behaviors. And finally, from the right insula to the occipital region, we see also this significant correlation with ADHD RS total behaviors, so that again, as connectivity goes up, ADHD RS scores go up as well. We wanted to look at the network level because obviously our brain works at the network, is in networks, not just in single areas. And at the network level, it would appear that altered default mode network interactions are associated with ADHD symptom change and executive functioning. So here, the default mode is a task negative brain network. It is active when we are at rest or not actively paying attention. And then there are several task positive networks, brain networks, in particular, the cingulo-opercular, the frontal parietal, the dorsal attention, ventral attention, and salience. So these are kind of outlined here in the brain, just to give you an idea of the kind of the dichotomy of the task positive and task negative. And the idea is that in all of our brains, these networks are anti-correlated, right? Okay, so here I've summarized the network level connectivity within our groups. So this is the cingular-opercular network to the default mode network is lower in the active versus sham group. And it's correlated with the ADHD RS inattentive scores as well as the total score. The salience network, which is primarily the anterior cingulate and the anterior insula, to the default mode network also decreased and significantly correlated to hyperactive, impulsive and total ADHD RS, as well as the inhibit scale on the brief, which we'll talk about in a minute. The frontal parietal network to the default mode network also reduced in connectivity in the active group and also associated with ADHD scores. There is one, the default mode to salience. So this is really the precuneus to the anterior cingulate was actually increased in the active group, the correlation went the other direction. So as connectivity goes up from the default mode network to the salience network, ADHD inattention goes down. And so I just wanted to kind of give you a background on a framework to view these results. So a single dose of methylphenidate does decrease connectivity between the default mode network and task positive network. High P factor, which is a psychopathology factor score that was derived from the CBCL in the ABCD study, are associated with decreased functional connectivity of the precuneus. So here we see an increase, and then increased connectivity between the default mode network and control networks. Frontal parietal, cingulo-opercular, and default attention network. So the idea here is that it would appear that TNS does help to normalize connectivity in brain across different brain networks, and this is associated with the ADHD treatment. And finally, we do know that there is a normative segregation across development with increasing within network connectivity and decreasing between network connectivity with age. So this is something that should normally occur with age, and I think TNS is facilitating that sort of development, leading to a decrease in ADHD symptoms. Okay, so In terms of predicting treatment response, given that the response rate was 50%, we believed it's critical to investigate which children are likely to respond to TNS. So we wanted to identify subject characteristics, either behavioral, cognitive, or EEG, that are associated with TNS responder status and predict ADHD symptoms post-treatment. And then we also wanted to test TNS-related change in these variables during the trial for engagement of treatment targets and underlying neural mechanisms. So in the previous slides, you've seen basically the neural mechanisms underlying active treatment. And then we also wanted to see which neural mechanisms might specifically be responsible for treatment response. Okay. So in this part of the presentation, I'm going to present data on responders separated from non-responders. And the way that we determined this, so in the active trial, the double-blind RCT, we had 16 responders and 15 non-responders. And here are the demographics. After the active trial was over, if a child was randomized to the sham condition, we then gave them the opportunity to cross over into open label treatment so that everybody would get some treatment through participation in our study. In the crossover phase, we had, out of 30 children, we had 20 children participate, and 12 of the children were responders and 8 were non-responders. In comparing the demographics of, age, sex, as well as clinical variables such as IQ, ADHD severity, Connors, there were no differences between the double-blind trial responders and the crossover responders. So these two groups were combined here for this total group of 28 responders and 23 non-responders. Okay, so I just wanted to show you what their ADHD RS scores looked like across the trial. Here along the bottom, again, you see time or week. And so here was the active trial, which consisted of 4 weeks of treatment. Again, we had the 16 responders and 15 non-responders. And then the sham crossover treatment, which was also 4 weeks. However, we did assessments every 2 weeks. This is why it looks this way and potentially a little bit more steep in terms of the slope. There were 12 responders and 8 non-responders. And the baseline observation was carried forward, meaning week 5 was used as the baseline for the crossover group. Here on the y-axis is the ADHD-RS score. Here in green is your active group. So children that were randomized to the double-blind active TNS group, here in the solid green line. And they were responders based on the CGI-I, 1 or 2. In this green dotted line are the children who were randomized to the active group, but did not respond. These are non-respond. Oops, sorry, my mistake. These are actually the children who were initially randomized to sham control. And then at the end of the treatment, after it was unblinded, they crossed over into open label treatment and then subsequently responded. This red solid line is the active group that were non-responders. So they had the active treatment, but they did not respond. So you can see kind of that same, initial small response and then a plateau. And then finally, this red dotted line is the group that was initially randomized to the sham control treatment. And then at baseline crossed over into active treatment and subsequently did not respond to treatment. Okay, so very different kind of dose response lines as we would expect. So as I said, responder status was determined by the CGI-I 1 or 2. A non-responder was considered someone that had a CGI-I of 3 or greater. We had weekly measures of the ADHD-RS as well as the BRIEF, which is a behavior rating scale of parent individual executive functions. So, and we're going to talk a little bit more about that. So this is just this is a clinical tool that I tend to use for neuropsych assessments. It measures executive functioning in kind of everyday life. And so there are T-scores, and so a score of 50 is average, and clinical impairment is somewhere about 68. So here on this graph, you can see several subscales that were significantly different, higher, worse in the responder group at baseline. So you can see here in the green line, these are the responders, the TNS responders. The red lines represent the TNS non-responders across these different subscales, which are initiate, working memory, planning, organization, and metacognition. And just looking briefly at the brief working memory score, for example, which is probably the closest to an ADHD score. Several of the items have inattentive sorts of questions. You can see in this correlation plot, so here is the baseline brief working memory score, and then the post-treatment ADHD-RS total score. And there's a strong correlation between, well, actually I did a regression. So basically this baseline brief working memory score significantly predicts the post-treatment ADHD-RS score. So these red dots are the TNS non-responders. These green dots are the TNS responders, showing higher brief working memory score, but lower post-treatment ADHD-RS total score. And just to show you a similar kind of the way the treatment response worked according to the trial, you can see here the active double-blind trial responders have a pretty strong decrease or improvement in the brief metacognition T-score, whereas the crossover group, so they were initially randomized to sham and then crossed over here into active, also have pretty significant improvement in metacognition, whereas the non-responder groups were actually just combined across the two phases, the active trial and the crossover trial. And you can see that there is virtually no change in the metacognition T-score. So this was a significant responder status by time effect. And just looking at the treatment change in metacognition, this brief metacognition T-score, and the treatment change in ADHD-RS is a pretty strong correlation between the two, suggesting that metacognition and inattention run together. I just also want to show you that it was amazing to me, the improvement across brief scores among the responders according to the trial. So here, this is just a T-score of the brief subscales. You can see here are several of the subscales that were significantly higher in the responders at baseline. And so the green are the responders, solid is baseline, hashed is week 4, so end of treatment. So you can see across the board, actually, that the responders were within the 50 to 60 range of a T-score, which is normal. Whereas the non-responders started high at baseline and pretty much didn't change, and were still clinically elevated, at least with a T-score of greater than 60 on most of the scales, and still quite elevated on the working memory subscale. This blue line indicates clinical impairment. So in terms of EEG, as you might have guessed by now, so we wanted to look at right frontal, since that seems to be involved in ADHD treatment change across the different frequency bands. We see that non-responders had higher spectral power across the different frequency bands relative to non-responders, and that baseline F4 alpha power was significantly predictive of post-treatment ADHD-RS total score. Okay. In terms of looking at the treatment change, again, here at baseline, the responders were lower and had subsequent increase in spectral power, whereas the non-responders had virtually no change from baseline in the solid line to end of treatment in the dotted line across frequency bands. We didn't have EEG in the crossover group, so this is just the double-blind trial. And so we were kind of underpowered, although it still came out significant. So basically, we used the treatment change in ADHD in EEG power at F4, along with the brief subscales to look at the area under the curve, so to predict responder status. So when all of these things were modeled together, we had pretty strong and pretty significant area under the curve, significant prediction of TNS responder status. So that suggests that EEG is a biomarker of the neural mechanism underlying TNS effects, and that the prediction of treatment response improves both when you have the brief working memory scale, as well as the planning scale, which is a subscale on the brief, EEG power, and then this is actually a sluggish cognitive tempo scale from the CBCL. So modeling these four things together, we have pretty good prediction. All right, so in this first blinded sham controlled trial of TNS, we had about a 50% clinical response rate, and this was a similar effect size to non-stimulant medication. It's well tolerated with mild adverse side effects and excellent compliance. And we really love that it can be administered at home by parents and then taken off in the morning. They go off to school and then they wear it again at night. FDA cleared as a monotherapy for children with ADHD 7 to 12 years old. It does seem to also remediate executive functioning deficits among treatment responders. And then the brief is a parent rating scale. It's potentially a simple and cost-effective method to identify patients more likely to respond to TNS therapy. I would just point out, though, that this is, the responder status, especially the area under the curve, and analyses were carried out on a small group. So we also feel like there is a need for more data and research to be done. So as a summary, the neural mechanism underlying treatment effects may be normalizing default mode network connectivity and interactions. This increased right frontal cortical activity appears to be a biomarker of improved executive functioning and ADHD symptom improvement. We believe that TNS normalizes the neural network functional connectivity and increases cortical activity in right frontal regions. That results in improved executive functioning and subsequently ADHD symptoms. And finally, future work on personalized medicine approaches for treatment interventions, both medication, pharmacological and non-pharmacological, is highly feasible and should be utilized more commonly across psychiatric populations. So the next steps, we're actually taking those next steps as we speak. We are funded to do a large multi-site randomized controlled trial of TNS to confirm and extend the treatment effects, to further test the underlying neural mechanisms, and test a baseline cognitive profile for prediction of treatment response to TNS. So the two institutions involved are UCLA and Seattle Children's. At the end of the study, we will have 225 completers. We are emphasizing a recruitment of diverse sample, and we also will over-recruit girls with ADHD. There will also be a 12-month open label extension to examine long-term treatment effects. This will be only at the UCLA site. And at the Seattle Children's site, they're going to do 3- and 6-month naturalistic follow-up to understand what happens subsequently after TNS treatment ends. We are also collaborating internationally with the UK. Katja Rubia has a similar study funded in the UK. They're doing, I think, 180 children. Wider age range, I believe it's something like 8 to 18. But we have been talking about kind of harmonizing our methods to make sure that we can examine and have some similar primary outcomes, so that we can look at our data together and have a very large sample. So if you are interested, please refer potential participants to, we have this website set up, UCLA, semmelUCLA.edu, ADHD and mood. And we also have this flyer. People can use this QR code to fill out a screening questionnaire, and then we will get back to them and let them know about their eligibility for the study. And that's it. That's our research group. I want to say thank you. I'm going to kind of leave it here on, oh, I guess I can, huh? Okay. Okay. Anyway, so thanks very much for your attention.
Sandy, that was a really great talk, and the fact that you're able to get FDA approval for your study is something that many of us can only dream about doing. I mean, the impact is clearly, you know, really huge for this work. It's
Thanks, John.
yeah, really, really great. There's a couple questions already. I have one question too. Have you have an experience yet combining this maybe with behavioral or cognitive or psychopharmacologic interventions? Is there a potential synergy there, either at the biological level or just behavioral?
There may be. We are at the early stages. So of course, at the early stages, you want to test whether it works relative to placebo or sham. And so that's kind of where we focused our efforts. I will say that we've done a couple of small pilot studies looking at other populations where ADHD is quite prominent and impairing. And those children have been allowed to stay on medication, and it seems to work fine, especially, you know, it seems to work in conjunction with the medication, especially if the child is kind of stably treated on the medication. We've been able to add in TNS and see additional effect that are promising.
Great, thanks. So we have a couple questions. Ayer asks, how long do the effects of these non-pharmacologic treatments last? How often do they need to be repeated in a day, and how is that monitored?
So that's a great question. It's a bit of an open question. We haven't really had a chance to, we'll be starting this long-term effect study. And also the 3 to 6 month naturalistic follow-up. So I think we'll know more at the end of the study in terms of long-term effects. In the previous study, we did do a 1-week discontinuation, and we did see a slight increase in ADHD symptoms in the active group. So I do believe the treatment will need to be ongoing, whether it needs to be every night, maybe not. I guess we'll find out a little bit more about that. And then in terms of using the treatment more than once per day, we instruct the families to just use it at night when the child sleeps and not to use it during the day. And they're limited because the electrodes are single-use electrodes. And so they're actually not able to do the treatment on their own more than once per day. So at least during the trial, we know that no one was using the stimulation treatment more than once per day. I don't know that it would be necessary. So in the long term, my guess is that the effects are not permanent. It doesn't cure ADHD, but that potentially what will happen is after an initial positive treatment, people might be able to use the treatment more sporadically, not every night for continuous treatment. But that's a hypothesis that we'll need to test.
Cool. Stephanie Freeman asks, well, first she says, amazing talk, which I think we all agree. Thank you, from Stephanie. Were any of the children in these studies comorbid with other disorders, including developmental delay or autism?
So autism is an exclusion criterion for us, as well as psychosis, as well as major depression. So there are children that have oppositional defiant disorder and anxiety and Tourette, but no, we have not studied this in children with other neurodevelopmental disorders such as autism.
You did such a great talk there. No more questions. I think it was a record clear talk. Maybe you answered everybody else's questions. Oh, here we go. I thought that would work. Mary O'Connor, will you be looking at actual changes in child performance?
Child performance. I'm not sure what performance in what domain. Mary, if you could clarify, that'd be great.
Yeah.
I mean, we are in the new study, we are actually looking at several different measures of impairment. So functional impairment in daily life. We are looking as a second tertiary outcome, we're looking at some cognitive academic performance change. So we are trying to look at functional change in addition to ADHD-RS symptoms.
You know, you talked about, you know, looking at maybe a personalized approach based on your predictors. What might that look like?
Well, we need more data. I mean, the simplest would be to use this parent behavior rating scale. In my analyses, the brief working memory scale, for example, does better than 50-50, but it's not quite as high as the 0.83 that you saw on that slide when it's just by itself, or just the brief subscales by itself. So I think that's, but you know, it's better than 50-50. It gives you, it gives you a moderate prediction. So I think we are going to try with a larger sample, we can probably try to refine what that baseline profile looks like, and hopefully identify the strongest predictors of TNS treatment response. I know EEG is not the most user-friendly of things, and so yeah, we would want to look at the value added effect of EEG, but I recognize that that's not necessarily deployable in the community. So whether there's some combination of other behavioral sorts of issues like sluggish cognitive tempo from the CBCL, some combination of ADHD symptoms, or the brief, I think that would be something we would be looking to something that would be easy to deploy in the community and in your office to identify those children who are most likely to respond to TNS treatment.
Right, and Mary clarified her question, which I think is a really, really great question. Looking at actual performance testing in the lab is an outcome.
Yeah, we actually have done some of that. I didn't show you the data because there was no findings. So I mean, it doesn't, so far what we've looked at are some computerized cognitive tasks like a flanker task, and that didn't really play out in the way that I would have expected, because I'm also a neuropsychologist. So yeah, so we're taking a look at some other sorts of probes, specifically around inhibitory control, which is what was kind of suggested by the right frontal finding. And but yeah, it may not, I mean, and then also reaction time variability, which is suggested by the default mode network findings.
And Patty Walsh, also great talk. What's the generalizability for the effects? So as we know, there are limitations to our current treatments on affecting things such as social function. Any hope for TNS in filling in these gaps?
Yeah, well, thanks, Patty, and I agree. That's part of why we wanted to include, so in the impairment measure, it looks at kind of impairment at home, social impairment. And so behaviorally, we are trying to assess generalizability outside of ADHD symptoms. And then, we're really pushing hard. We literally started the study last week, so that's taken a lot of my mental energy. But as soon as we are smoothly going in terms of the study, I'm really trying to get out there to recruit diverse samples and girls, so that we have a more representative sample of our community, and we can better understand if there are any variations in response based on demographics or things like that. So I think that's what we're trying to do to enhance generalizability of the study.
Vindia Fernandez asks, I was also wondering about long-term academic functioning and how that might be assessed either with testing, questionnaires, or report cards.
Sure. Yeah, no, that's a great question, Vindia. I mean, again, it's hard because, I mean, I think we will do that in the long term, the 1-year follow-up extension study. It's going to be a little bit skewed because if you're not a responder to the treatment, you're probably not going to stay in for a full year. But we'll do some academic achievement testing at the end of the year follow-up, so to see whether or not there are gains in academic achievement. and functional impairment. But yeah, I mean, I would expect that there will be, and we're gonna look for that, but just I'm not sure what will happen. That's the exciting part.
I have another question. Do you think there may be a dose response effect here, that non-responders or partial responders might respond to more treatment? And also, is it possible that some of the non-responders might not have gotten the full dose? I mean, I don't know if the device maybe wasn't applied correctly, or
Sure.
comes off, or whatever it is.
Sure. Yeah. Well, so in our first open label study, it was actually a 6-week treatment. And we did a dose response curve. And essentially after week 4, it plateaued, which was kind of our justification for shortening the trial to 4 weeks. And then in addition, in doing the responder analysis, I did look at some of the children who were in active treatment, and some chose to stay in for a little bit longer. And the vast majority did not show a lot of improvement past the 4 weeks. So I think there always could be the case where there are some kids that would benefit from longer treatment. But the majority of the group, it would appear that we're getting the majority of the treatment effect in 4 weeks. Your question about not applying the electrode correctly or not wearing it correctly, I think can be an issue. We do monitor compliance very closely. So we ask the parent to tell us what time they put it on, how long they wear the device for, basically at night, for every night that they're in the study. And we're also at this point tracking stimulation levels. So we'd like to know whether the level of stimulation is, I mean, at this point, it's just adjusted according to comfort level, but we'd like to know if, for example, stronger stimulation leads to better outcomes. So there are lots of questions that we're trying to answer, and they're all good ones. And, I wish we could answer more. I've gotten lots of questions about age, what are the TNS effects in older children. I've gotten lots of questions about comorbidity such as autism. And we're just trying to take a couple of questions at a time and tackle the ones that we can do. And then, hopefully either we will go on to do more and look at these other populations older, or someone else will.
Great. Well, we don't have any other questions. I don't know if you have any final thoughts or anything that you want to say. Otherwise, I think we can go ahead and wrap up.
Yeah, I mean, just that we are excited about developing this non-medication treatment for ADHD, and we've seen a lot of excitement in the community. Really would love for people to get the word out that we're open for business, and we welcome all children, and we are actively seeking all children to come in so that we can enhance generalizability and better understand treatment effects and predictors of treatment response. So thanks very much.
Well, thank you again. It was a really great talk.
Thanks. All right. Bye-bye.